Hello everybody, good day. I'm Dr. Bradley Lamm. I'm here at the St. Mary's Medical Center where I'm the Chief of Foot and Ankle Surgery and the Director of the Foot and Ankle Deformity Center at the Paley Institute. And today I'm doing a Facebook Live presentation to you. I'm very excited about this because this is a brand new classification for brachymetatarsia. One of those conditions, congenital conditions or birth defects that is pretty common, and I felt it required a classification to help best plan for treatment. So this is a bit about what brachymetatarsia is, and also this new classification which I'm happy to share with you today regarding that. What we're going to talk about today is this, which is brachymetatarsia. This is a case of a fourth metatarsal that was short, did a gradual lengthening, and the after. So there are many different procedure options, and as I mentioned, we want to create an environment where surgeons and patients can understand not only the deformity and then figure out what's the best treatment option for them. There are definitely different treatment options out there. Sometimes these brachymetatarsia patients have also multiple metatarsals that are short, so we need to make sure that this is all addressed all at the same time, which is something that I do commonly, not one at a time, but as a unit, and also bilateral or both feet together. So this can be kind of a one process treatment. So this is a topic that I've been interested in for a long time. I've written book chapters, I've lectured international, national. It's something that I've done a lot of research on, and like I said, I'm happy to share with you this new classification research today. This article I wrote describes this newer technique that has really advanced this treatment and allowed patients to be very functional. The problem for a long time was we could grow the bone or lengthen the bone, but it created some functional deficiencies, and patients had difficulty with stiffness of toes, toes that weren't positioned correctly, and a lot of problems with function after lengthening surgery. And so this article that I wrote takes advantage of holding the toe in the right position at the same time of lengthening the bone. So it's an important addition to allowing this condition to be treated successfully. So I've also written problems, obstacles, and complications articles about this technique. Since I've done over 1,000 of these procedures, I've seen complications, I've seen problems, and know what to expect, as well as we can now predict these problems and avoid them ahead of time. So patients exhibit, of course, that dorsally displaced toe. They have difficulty with shoeing, pain, and the appearance of the toe is not cosmetic as well. So it's a functional and cosmetic problem. You can see on the right, sometimes it's traumatically induced, a childhood injury that slows the growth plate down. Sometimes it's congenital, meaning born with this condition, that as the child grows it gets to be more and more dramatic as the growth of the foot continues. The toe growth does not continue. So this is very prevalent. 1 in 1,800 to 1 in 4,500 patients that are born with this condition. So you're not alone if you're tuning in here. This is something that a lot of patients have. There's a lot of my patients and other patients out there that can share their story with you, but it's something that I know a lot of my patients come in and say, oh, I didn't realize how common of a problem this was until I did some research. The female to male ratio is 25 to 1, and like I mentioned, it's a premature growth plate stoppage of the metatarsal bone. And it is also a ray deficiency, meaning the ray includes the little toe bones, the phalanx bones in the toe. So not only is the metatarsal short, but so can be the phalanx bones within that toe. So here's this example that we just saw. The traumatic is on the right. You can see that the phalanx bones, which are those small toe bones, the fourth is longer than the fifth. But in the example of the congenital, you can see here the fifth toe bone, the phalanx bone, is longer than the fourth toe. So that's an identifying radiographic factor that I could evaluate your foot and see that. But this is something that is either or a cause of this condition. It's as I mentioned, dorsally displaced toe, creating a bunch of functional and cosmetic problems, and multiple metatarsals affected is called brachymetapodia. So brachymetatarsia is, if we look at the x-rays, it's a toe that's sort of out of joint. And so, as I mentioned, it's important, that article that I wrote, the technique that I developed, helps to put that toe down in line with the metatarsal instead of sticking up, and it can stay back in joint while we do the lengthening or the corrective surgery. As you can see here, kind of the outline of the joint, how much the toe's sitting up in those examples. Short first metatarsals are also prevalent, and they're a little bit different in their appearance because the metatarsal grows down, and so you have to be very mindful. If you have this particular problem, you have to, as the surgeon or the patient, understand that if you lengthen down further, you're going to create more prominence of the bone. You have to lengthen with the plane of the floor, so that way you don't create further toe or toe joint issues. So the first toe is a little bit unique in that how the bone grows is very critical to be able to be successful with this condition of the first. So here's the new classification system. I made it rather simple, kind of an A, B, C, D classification system, something that's easier for doctors and patients to discuss. And the thing is that we're going to go through each one of these, but you can have many different variations. And I know there was a great question before the Facebook Live launched here that a patient asked me about a short toe and having a condition called MHE, which is something that we treat here at the Paley Institute quite commonly. And some of these unique deformities or orthopedic deformities, whether it's hip, knee, leg deformities, upper extremity deformities, it's very common that these patients also have foot and ankle conditions. So, and brachymetatarsia is not uncommon in these patients with other orthopedic conditions. So it's very important that you see us at the Paley Institute, because this is something that not only do we treat unique foot and ankle deformities, but also other orthopedic deformities. And so you have to have an x-ray to see which bones are short or which combination of bones are short, and then figure out the best treatment plan from there. So if you have further questions, please send them in while I'm doing my discussion here, and I'm happy to answer them at the end. And so looking close into this descriptive classification, what you see here is a 4A. It simply means that the fourth ray is short. So basically, it can be a little short, a lot short, but we know that all the bones in that fourth ray or the fourth metatarsal is short. So this is kind of the typical appearance in most x-rays of most patients. You see kind of the short appearance of the bones illustrated here. A stands for axial, meaning the distance is short. The typical distance is around 15 millimeters of shortness that most patients have. The next slide is the classification of B. So this is a, let's see if I can get this working here. It's leaving us in suspense. All right. Should work like the phone, right? Here we go. All right. So B is bowing. So that's what B stands for. So sometimes I see patients, whether it's an initial consultation or since I see a lot of revision surgery cases or patients that have been to another doctor and then find me as kind of the expert in this particular surgery, I find that this bowing is common. And so it can be bowed from a previous attempted surgery, or it can be bowed from the just growth and position of the foot during this growth plate stoppage. So 4B means bowing. So this is a little bit different technique than kind of the standard technique that I was kind of describing before. We have to straighten the bone before we lengthen the bone. So the osteotomy or the realignment has to happen as well as the lengthening. So this is very important to consider the bowing. If you have the bowing, it's a little bit more technically challenging to accomplish both of those. 4C, 4 means the metatarsal, and C means congruency. So sometimes the bone is short, but there's also a joint problem. So if it's in joint or slightly out of joint, it's fine. But if it's totally incongruent, not in joint, then that leads to another type of treatment plan where we have to really not only grow the bone, but also correct the toe problem or the joint problem as well. And then 4D means that there's digital problems, or in the fourth toe there's also some digital deformity. That also happens in revision surgery. Sometimes it happens where there's abnormally short phalanx bones or other conditions we see that the digit is affected. So there's a special classification for the digital deformity as well as the metatarsal deformity. The other important thing is you can combine these. So say it's short with a bowing problem. You could say it's an AB, meaning it's short and bowed. So this is a great kind of starting point so we can understand the radiographic deformity. And then what I did in a recent article is I combined what we would do surgically with what we find with the radiographs. So that way it's a very clear plan for you when you see me as to what's the best scenario given your clinical classification of your condition. All right, so next up is what are the surgical options, and we have very many of those different options. And you can do acute lengthening, you can do gradual lengthening. Acute lengthening means just putting a bone graft in, opening it up, putting a plate and screw and bone graft in there to grow the bone. Usually it's either a cadaver donated bone that's put in there or a bone from your heel bone that's put in there. That's the acute lengthening. Gradual lengthening is growing with an external device, growing the bone slowly. And then a combination, sometimes these techniques are combined together. Here's an example of a failed bone graft technique. This is sometimes called the one-stage technique. And we can critique all we want, but this has left non-union and also left a small piece of bone that didn't heal because the bone graft didn't incorporate. And also the length was not obtained. So even though the bone graft was put in, as you see here, there wasn't enough bone put in to grow the length appropriate to where it needs to be given the metatarsal parabola. So it should be somewhere out here, the bone, and not back here. So you can see that here. And this is what it clinically looked like. This technique of bone grafting or single stage requires a longer incision. So this is a case that I was sent to me for revision. And so the concern here is this metatarsal head going to survive or so forth. So I'm not a fan of the one-stage method. It is sometimes something that I do given the clinical scenario. Usually if it's not a dramatically short toe, you can add bone graft safely. But if the toe is shorter than, say, 10 millimeters, then it's a reasonable option. Longer ones, acute lengthenings or the one stage can create some problems, and you have to be aware of those. So when we lengthen, it's important to plan it out, and you need to know the parabola distance. And what I do is I calculate, if I'm doing a gradual lengthening, which is the external device, I plan out if it's going to be 15 millimeters of shortness, as you see here, the yellow dotted line, we want to lengthen the bone. 15 millimeters, it takes at 5 millimeter, half a millimeter a day. It takes about 30 days to grow the bone. Usually we wait about 5 days after surgery to start the lengthening. So then that's about 35 days, and usually it takes around 4 months to get fully healed after about this average amount of lengthening. So it's about a month of growing the bone, 3 months of healing the bone. Everybody heals at different rates, but once it's healed, then the fixator can be removed safely so that there's no residual bowing or shifting of the bone because it has to be solidly healed. So just to show you some of the techniques, the wires going into the foot here to hold the fixator. It's very important how the wires and the fixator is placed to grow the bone in the correct trajectory, so it stays at the level from the kind of the top down level, how prominent is the metatarsal, but also in the appearance of kind of side to side, that it's not being lengthened too close to one of the other metatarsals. Patients talk about width of the foot because the toe was so short, and they feel like sometimes after lengthening that the foot feels a little wider, and that's true because the fourth toe or whatever toe it is kind of in a better normal position, and some patients do feel a little bit more width of the foot after the procedure. So this is the old method of kind of pinning the toes. We no longer do this because that created some stiffness of the joints. So now we use this technique. This is just a wooden bone, a model bone, and we grow the bone back here between these 4 pins. We stretch out the joint and hold the toe in the right position. And this is my technique that I described in that article I mentioned. So we're putting the toe in the right position, and we're preserving the joint, because as we grow the bone, we don't want to crush the joint. The joint's going to stay open and be able to grow with the bone. So this is a very safe technique, and what this technique does is preserves function and motion of the big toe after the surgery. Double tap. All right. So can I move on here for a second? All right. It's on Zoom mode. Okay. So this is the technique I just showed you, kind of on a clinical example. This is the osteotomy incision where the bone is broken so it can grow. And then you can see how the toes all line up and are sitting in a good position here. So here's just the anterior view, top down, and showing how this this technique works, keeps the toe straight. So, let's see. This is shown to be a really good technique, as I mentioned, with this capturing the toe and holding the toe in the right position. So. I just hit the arrow. So, let me see if this keeps blowing up on me. If you have questions, you can send them to me. We're Facebook Live, and we're happy to be here. So, here's the axial image showing you the toe position and how the fixator's held there nicely. And here's the before and after. You can see basically the toes sitting up. Now the toes in good position, good length. And we do bilateral cases all the time, means both feet. Patients are allowed to weight bear right away. That's important. As you are able to walk, you don't lose strength of other muscles, and you can be very functional while going through this treatment. And this is a case example of a 13-year-old, 14-year-old patient who has bilateral fourth brachymet. And this is the lateral view. You can see how the toe sits up. And we did osteotomy, lengthening. Here's the difference here of shortness of the metatarsal of the fourth. And this is just calculating how much we need to grow the bone. And just some intraoperative pictures showing the pins being placed orthogonal to the bone and in a good position. And small incision for the osteotomy. And showing how we do this through kind of minimal technique, where we just do a couple drill holes and then an osteotome to create the break. There you see a couple drill holes through the bone. And some more, which weakens the bone, so then we can do a bone chisel to do the osteotomy. So it's it seems a little bit harsh, but it's actually better to kind of crack the bone like this than it is to saw it with the saw, which creates a lot of thermal injury or heat, which can injure the bone cells. So this is a very good way to do it because it's a low energy fracture of the bone created. And so here you just see how we do that, and then kind of, like I said, twist the osteotome to get a little bit of a crack there, and then that allows the bone to grow very readily. So here you can see on the x-ray how that's done, the osteotomy. And then we do the bone growing technique with the external fixation, where you're turning a little bit every day to grow the bone. You can see nice new bone formation here on both sides of this patient. And you can see that she's healed very nicely. You can see that the function, which I was mentioning, which is really important, is not only we want to gain the length and make it look good, but we want to make sure it works really good. And so this technique allows for good function after surgery. And this was probably about 2-3 months after surgery. Small scars, they'll fade with time, and good overall toe length on both sides. Complications can occur. This is not an easy surgery. It definitely looks easy, but it's very complicated, as based on all my previous discussions about classifications, angles, positions, all this and that. But toe position is something that is critical, and as I mentioned, holding the toe in the right position during the lengthening is critical to maintain good position so you don't get this kind of lifted toe or deviated toe. The other thing you can see is if the fixator isn't built correctly, you can get angular deformities. In this particular case, also you can see the joint was not protected, and now it looks like there's some narrowing of the joint and some issues with the joint. So understanding of this is critical for good results. And this patient had an over-lengthened metatarsal. Also, you can see that the toe is dislocating or shifting out of position because of that longer growth. You can see that the bones are very close to each other here, meaning it's kind of angulated. We don't see much bone growth, so maybe the rate of distraction may not be as slow as it should be. But these are all things that can happen that we have to be very mindful of. And so I think this one really drives the point home that this is a young 20-year-old girl who came to me from Canada having had surgery somewhere else, and now she used to be a half marathon runner. Now she can barely even walk without pain because she has this flattened metatarsal joint. You can see it also here, and this has created basically stiffness, and so she can't really bend or push off her foot because she's got so much stiffness. And so this really shows that having that technique of protecting the toe, kind of understanding of when you grow the bone, all the soft tissues are going to pull back and kind of jam that joint. So the technique is very important, the classification system of kind of what do you have, what's the best treatment, how many pins do you need, what is the exact treatment protocol, what's best for you, all very critical. And then finally, as I mentioned, bridging the joint or the metatarsal phalangeal joint, really important for function. The direction of lengthening, you don't want too much length. Of course, we want to make it look good, but we want to not go too far that it impedes your function. And then it is a dynamic process. A lot of doctors don't understand that. A lot of patients don't understand that. It's not a set it, forget it kind of surgery. This is something that if you do the gradual lengthening, you must have a good relationship with your doctor, many follow-ups, good communication, so that not only does it go well for you, but also is successful. I'm just going to show you a couple before and afters here before I close. You can see before here on the left and after on the right, bilateral fourth brachymetatarsia. Treated with gradual lengthening. You can see here the before x-rays, the two short fourth metatarsal bones, and now you can see kind of equal length parabola bones, or parabola of the metatarsal bones. Here's another before and after. You can see that not only does the fourth toe get corrected, but it pushes the other toes into the more normal position. So a lot of times I don't have to do surgery on the adjacent toes because just by doing the lengthening and putting the toe that's short where it should be corrects a lot of the problem. And so here you can see before and during. This is multiple metatarsals being lengthened, bunions being corrected all together. And that's the before, during, and then I think I have the before and after here on x-rays. You can see that very short, 3 metatarsals, 2 metatarsals here, all lengthened out to the appropriate distance. And here's this before and after, kind of the clinical pictures of the before and after. Again, another case of a first met and fourth met here at the end. And sometimes bridging of the big toe joint, again, is also important for this particular case as well. So I'm hoping you enjoyed the Facebook Live, and I'm going to leave my contact up here. Here's my office number and my email. I'm happy to take any questions. I know that we have a couple come in already, so let me have those.
How long is the actual surgery?
So the surgery is not too long in my hands. Sometimes it can be 30 minutes per metatarsal, and it's just due to the experience that I have, but usually, again, it's around 30 minutes to an hour per metatarsal, depends on the particular case. But I always say that it's not kind of how long it takes me, but it's how well it's done, and that's what we always strive for here.
My son has MIG. What kind of problems could lead if not treated?
Okay. So, great question, and a lot of patients ask this, especially patients that have multiple other orthopedic conditions and multiple other surgeries. So if this condition is not treated, it can create some functional issues and balance issues. I have a lot of patients who feel that they kind of are a little bit unbalanced, and after the surgery they feel so much more balanced. I've treated patients, adolescent patients with this condition, kids, all the way up to 65, 70-year-old patients who had just wanted to have it done because they've been bothered all their life by it. So I can see treating those patients, the whole dynamic of the young kids with this condition, and then the seniors with this condition, how much it does affect the foot over time. And what happens is, because toes are short, the other toes go into that position, and that can create hammer toes, it can create calluses, as mentioned, the balance issue, and sometimes even skin issues because of the kind of malposition of the skin being kind of pinched, or crevices or fissures or things like that. Is it something that absolutely needs to be treated? Each case is different, and it's something that we urge you to be evaluated. And also, as mentioned before, it's great to have a treatment plan. If your child or you have a condition that involves these unique congenital problems, it's best to kind of have a great picture of kind of what it looks like for as a young child, a growing child, an adult, and what's the best procedures, and can they be combined. And here at the Paley Institute, we can afford you all those comforts of kind of making that plan for not only the feet but other orthopedic issues.
Would you recommend correction for a teenager who has brachymetatarsia on one foot, or is it better to wait until he's older?
Yeah, this is a really good question. So when to intervene for brachymetatarsia? So I've written an article which talks about foot growth, one of the only articles which kind of predicts foot growth and how to predict foot growth and how much foot growth is going to remain at certain ages. So say a patient is 13, how many more, and it's a female or male, how many more millimeters would that metatarsal grow? Is this something that we can intervene at that time at 13 before they're fully mature bone growth wise and not have an effect on the overall length? Or is it something we should wait until the metatarsal is fully mature from a bone growth standpoint, an x-ray standpoint, and then intervene? In general, it's best to kind of wait till the bone is almost fully mature or fully grown, so then when we do the lengthening we can be 100% sure of the position we leave the metatarsal, because in the foot every millimeter matters as far as the distance, the height, all that can be felt by patients if it's not corrected accurately. So it's a patient-by-patient decision, but here at the Paley Institute we have developed all these growth apps and written these articles on prediction of growth in children, so we can afford you that prediction and that information as to when might be the best to intervene for this procedure. All right, great. Well, those are all great questions, and I appreciate you tuning in. Again, I'm Dr. Bradley Lamm, head of the Foot and Ankle Deformity Center here at the Paley Institute in West Palm Beach, Florida. You can reach me at my email at blam@paleyinstitute.org, or you can call my patient coordinator, Angela Edwards, at this 561-844-5255. And I hope you appreciated the information. And as mentioned, I'm happy to answer any questions via phone or email. And I'm looking forward to talking to you or meeting you. And have a great day.